and I'm really happy to welcome you to our webinar today. My name is Rita Croneiss, and I am the Virtual Learning Community Coordinator with the Academy of Peer Services. And this is actually the fourth in the series on talking about tobacco. It's with the program New Jersey Choices, and it's on choices and peer support. And so without further ado, let's get started. So the Academy of Peer Services, most of you are probably familiar with us, but we are a program that's funded by the Office of Mental Health. We are managed by Rutgers University School of Health Professions, Department of Psychiatric Rehabilitation, and we operate in partnership with the New York Association of Peer Support, New York Association of Psych Rehab Services. And we have tech support today by our NIAPR support specialist, Mariam Hassamuddin. This session is being recorded, and we would like to ask that if everybody could just have your audio on mute and your camera turned off for the duration of the presentation, that would be really helpful. We're recording so that we can continue to offer these series on our Academy of Peer Services. If you have questions, you can use the chat box to ask questions. You'll also note that if you click on the CC at the bottom of your screen, you can turn on closed captioning so you can watch the closed captioning happening as the webinar goes on. You can also, if at various points in time, if we stop the screen share, you can use gallery view or speaker view to see everybody in the session or just the one person who's talking. And you would do that by clicking on the view option at the very upper right corner and select either gallery or speaker. I want to make sure that it's really clear that there is no certificate that goes along with this particular webinar, because the recording of this webinar will be converted into a course that we offer on the Academy of Peer Services. It will be available within about a month, and at that time you'll be able to take the quiz and complete the course evaluation for a continuing education credit that will be worth 1.5 credit hours for a New York Peer Specialist certification or certification provisional towards a renewal of that certification. It's not, the credit does not go towards initial certification, but if you need continuing education credit for the renewal of a certificate, then that's where the continuing education credit is applicable. Our presenters for today are Trish Dooley, she's the Director of Choices. Lisa E is a Choices Consumer Tobacco Advocate. Azim S and Deidre S, all three of them are Choices Consumer Tobacco Advocates, and we'll talk more about that and how it relates with peer support. We have a couple of moderators for today. Susan Freelander, who's the Director of Community Integration and Wellness Initiatives at the New York City Field Office for OMH. I'm the coordinator for the Academy of Peer Services. And Amanda Sake is the Special Assistant to the Commissioner and the Director of Consumer Affairs. We have some objectives for today that will actually get covered when we get into that portion of the training, so I'll defer to that. And I just wanted to share this one quote from Mark Twain: "Giving up smoking is the easiest thing in the world." I know, because I've done it thousands of times. So with that, I'd like to turn it over to Amanda to talk a little bit about why talking about tobacco is so important.
Thanks so much, Rita, and welcome everyone. Thank you for joining us today. As you know, the Office of Mental Health, we're very committed to integrating a holistic health and wellness approach in all of our services. Folks could go on mute. Thanks. And we know the importance of peer support in supporting that holistic and wellness-based approach. So we find it incredibly important, to have these conversations talking about tobacco with our peer workforce. And tobacco use disproportionately impacts people with behavioral health conditions and reducing the lifespan. And as we've seen with the COVID-19 pandemic, even more so disproportionate health impacts for individuals with behavioral health conditions. And tobacco use can also have a negative impact on recovery and community inclusion goals. Go to the next slide. So, as Rita said, this is the fourth webinar, so it's a continued conversation, but we're always open to starting the conversation where we can honor the space of the values, principles, and practices of peer support, and having conversations about tobacco, about the individuals that we work with. And we're looking to create opportunities for tobacco champions and influencers in the peer support community. And please contact me. I'll put my email in the chat box as well if you feel passionate about addressing tobacco use in your role as a peer worker. And with that, I believe I'm handing it to Susan Freelander.
Hi, everyone, and welcome. I'm glad you're all here today. As you may have heard in our previous presentations, a number of years ago, I think it started back in 2016, I began doing some work out at Creedmoor Psychiatric Center in Queens. And we had been asked to assist some of the housing providers there, because when the campus went tobacco-free, what people noticed that a lot of folks were simply smoking indoors rather than outside. So we spent a lot of time just hearing about the issues and what was going on and what solutions people had tried. And I learned some really valuable pieces of information. First of all, and this is actually something I knew beforehand, peer supporters can play a critical role in any aspect of recovery-oriented work. And there's simply not enough peer support for tobacco interventions. We in New York State really don't have peer support groups that are focused on tobacco or peer education that focuses on tobacco. So I recognize that was an important need. Also, we tend to really focus on cessation. You know, people talk about smoking cessation as almost the only goal. And it became very clear to me that there are a number of folks who are using tobacco who are simply not ready to quit now. And if we only talk about cessation, it kind of excludes them. So I envisioned an approach where we could provide a variety of tobacco interventions to meet people where they're at. And finally, another thing that I learned that I think is very important is that people, and when I say people, I mean staff, prescribers, as well as people who use tobacco, and they may be staff and prescribers, or they may be people who receive services, that people need more practical information about how to properly use nicotine replacement therapy. Because a lot of times people will use products like the patch, the gum, the inhaler, etc., but not use it properly, and then they're not getting the benefit, and they will say that it doesn't work. So that's really informed a lot of my tobacco approach. And what we want to hear from you ongoing is how we can help you as peer supporters be more effective in how you would address tobacco use. So please, if there's anything that we can do for you that would be helpful for you as you address tobacco use, please put that in the chat, and we're going to make note of that. So thank you. And at this time, I am very, very excited to turn this over to Trish Dooley, who is the director of NJ Choices. I have been a great fan of their work for many years. I've seen their presentations that they do, and it's just wonderful. So hopefully at some point we can emulate what they do in New Jersey and offer that throughout New York State. So Trish, take it away.
Thanks so much, Susan. Great to see you, and thank you, Rita, for the introductions, and good afternoon to everyone who's here tuning in with us in this virtual setting that's that we're all sort of I mean, we're used to it by now, but it sure is different from the way that we usually do things. But we're going to talk a little bit about how we have pivoted during this time. So I really appreciate you being here and talking about this topic with us, because I feel like many times tobacco really takes a back seat to so many other pressing issues health and wellness issues that folks are dealing with. And so we are so happy to have you here. So like Susan said, I'm Trish Dooley. I am a clinician at Rutgers University in the Department of Psychiatry, in the Division of Addictions. I've been there since 2001 and been the director of Choices since 2010. So the work that I've been doing, it's actually like 20 years now, which is so hard to believe, has really been focused around research, education, and treatment around addictions, especially with a focus on tobacco and mental health. And so I'm so excited that the Choices team is actually with me today as well, because they are really, at the cornerstone of the success of this program, the work that they do. And that's Deirdre, Lisa, and Azim, and you're going to be hearing from each of them today. We are actually all also former smokers, so we have that experience with what Mark Twain quoted, which is we had a lot of times trying to quit, and it takes a little while sometimes. So I also want to start by just kind of putting it out there and acknowledging an issue regarding the name of our program. So the name of our program is Choices, and that stands for Consumers Helping Others Improve Their Condition by Ending Smoking. And so I know that, oh, I think someone else is talking, but at the time that we were founded, the word consumer was sort of the preferred term. And because that's part of our title, we've kind of continued to use that term, but I'm sensitive and I understand that there have been updates to the language. So I hope that when I do use that term, that it won't be offensive. We're sort of trying to work within the context of our branding, which has been in existence since 2005. So like I said, Choices stands for Consumers Helping Others Improve Their Condition by Ending Smoking, but it also reflects this idea of tobacco use as, something that everyone has the choice to either do or not do, engage in treatment with, or not engage in treatment with. And so we always want to make sure that that's at the forefront of everyone's mind, that we're not in here to force anyone in any way, because we know how that feels and we know that that's not really always the most effective. So next slide, please. So first off, we're going to talk broadly about smoking in the general adult population, and then we'll focus more narrowly on the mental health community. Also, we want to talk and give you a little bit of sort of highlights of the program that we have in New Jersey. We'll talk about the history of our program and what we're doing these days, particularly during a pandemic. We're also going to have some specific information, and you'll be able to see how we're incorporating aspects of the COVID-19 pandemic that, within the context of our work. And then what I'm hoping is that, some of this information, as you're sitting in listening, you can kind of think through how you may be able to adapt and use some of our ideas in your own work. So over the years, we've trained well over 300 peers in multiple states in sharing this message with them, so they may in turn share the message with the groups that they're working with. Okay, next slide. So this is just sort of taking a look at global trends and, and I don't like to be doom and gloom and scary, but this is just, we always like to put this out there just to kind of orient ourselves to the devastating impact that tobacco has globally. So globally, around the world, tobacco kills 8 million people, and that was data from 2020. And it's actually interesting that that's up from 5 million in 2012. And so how can that be? Aren't people smoking less? What's happening? Well, what's happening is that, tobacco has really taken a foothold in many developing countries. Big tobacco has gone in there with all of their money and influenced a lot of behavior in developing countries. And that seems to be, adding to the increase. And so then the next box here, which says tobacco kills more than 480,000 US citizens per year. I think, we've been saying this for many years. And again, this number is up from 2012. In 2012, we had 440,000. Now we're up to 480. And I think it's becoming more salient for people as we're seeing things every day about the pandemic and how many lives are being lost. So people are becoming more attuned to loss of life. We've been talking about this number for years, but somehow we never made the 6 o'clock news. We're not in the news with lives lost due to tobacco. So, it's sort of just something. Oh, I can hear someone else talking. So we're looking at almost 500,000 people per year who are dying as a result of tobacco use. You can see in New York alone, 28,000 individuals passed away as a result of smoking. And then just looking at the global cost to the economy of somewhere around $200 million. And these are things that are, healthcare costs, sick days, lost productivity, and things like that. And so if we do the next slide, I just want to see. Okay. Oh, yep. Okay. So I wanted to try to do an experiment. Usually when we're live and in person, we can kind of poll the audience. But if I were to ask what you thought the US smoking rate was, if anyone wants to share in the chat box what they think the national percentage of smoking is, I would welcome you to do that real quickly if you feel inclined to. And we can take a look and see what some of those numbers are. I see 80%, 55%, anyway, 30%. All right. So 45%. So those are the numbers that we do typically hear and see when we are out on the road asking that question. But 60%. So, but Rita, if you would pop in those actual numbers, I think that would be helpful. So it's really surprising to most of the people that we talk to that the actual rate of smoking in the United States is somewhere around 16%. I've even seen some data recently where it's even as low as 13.7, so it varies between 13.7 and 16% nationwide among adults. And so, and in New York, you can see you're even lower there. This map just kind of, the darker states are states that have higher rates of smoking. But in the US, the rate of smoking is 16%. So, hey, okay, we're doing pretty well, right? We've come a long way, baby. We were 50% in the 1950s and kind of the Mad Men era. But nowadays we are, as a nation, the numbers are low, and look at New York State, even better. So, however, let's look at the next slide, which is to say that, despite that the fact that we've come a long way in this country, people diagnosed with a mental health or substance use disorder haven't benefited as much from this reduction. And so, and you can sort of take a look, if you can see these rates of smoking, any tobacco products and then cigarettes specifically, people who have any sort of mental health condition sometimes can be almost double and even more in some cases the national average. And so, and some diagnoses such as schizophrenia have sometimes rates of up to 70%. And so, when we look at that, we feel really troubled by that. We feel like, that's sort of what are we doing wrong here? So if you go to the next slide, rather than just looking at overall population trends, it may be more important to examine what's happening in the remaining subgroups of smokers. So from this data, we can see that from 1997 to 2011, the smoking rate, so that top box, that top line rather, with the boxes, those are rates of smoking in the past month by people who reported any psychological distress from 1997 to 2011. And so that number started at 43.6, it ended at 42.1. If you look at the line beneath that, those are smokers in the general population who don't report psychological distress. And so they went from 24% to about 18%, right? And so that's what we would call a statistically significant reduction. So in the general population, we see this decrease. What the heck is happening for folks within the mental health community? Why is that? In the words of Marvin Gaye, what's going on? What's going on? Why isn't there that reduction? So look at the next slide. There are still 34 million smokers, in the US, and these are the groups that are still smoking. So if you take a look at these groups, they are groups that, typically also many of them experience other health disparities, and it's really no different with tobacco. And you can see there that these are the folks who are still consuming cigarettes, and our group is in there, people who report serious psychological distress. So if you look at the next slide, if you think about it from a societal perspective, it really is a social justice issue. Why haven't these great policies, these campaigns, this messaging that has done so much to reduce smoking overall in the general population, why hasn't that reached members of these various groups that are noted here? So people who are poor, people who have less education, people with mental health concerns, as well as folks in the LGBTQ plus populations. And so, the Truth Campaign came out with this informational sort of campaign, again, sorry, that sort of is looking at it like, this is vulnerable populations. What's happening? Why isn't smoking being addressed? So if we look at the next slide, we're just kind of focusing in on tobacco use among individuals with mental health issues. So we can see that almost half, 44% of all tobacco consumed in the US is by people who have a current mental health disorder. Mental health, people in the mental health community tend to have higher rates of heavy smoking. They're more effective and efficient smokers. Well, that sounds really funny. What does that mean, an efficient smoker? What that means is that people who are, the people we're working with tend to take more drags off of each cigarette and inhale more deeply. And so, well, what does that mean? That means that they're more dependent, right? So those two things combined, the higher rate of smoking plus those deeper puffs and more frequent puffs, equals more dependence. And what does more dependence mean? Well, that means it's harder to quit because you're physically more dependent. And so when you do try to quit, you have more significant withdrawal symptoms. So that's the thing that, that we have learned over time, and that we try to impart to our peers, that, listen, it's not a moral failing that you can't quit. You're having a tougher time because you may be more dependent. So let's talk through that. Also, many consumers have reported to us that they've tried to quit many, many times and have been unsuccessful. Okay, next slide, please, Rita. So this data came out in 2006. I'm sure many of you are familiar with this. It is older data, but what it said at the time was that people with serious mental illness were dying on average 25 years earlier than the general population. And I know that there have been subsequent studies that have lower estimates. But I say this, and I always use this because this was really important at the time that we were kicking off our work, to really sort of shine a light on what was happening. And this data is based on information which I'm going to show you on the following slide. So Rita, if you would move us to the following slide. So this was a study of clients who were served in the mental health system in 8 different states, looking at the cause of death. Why was there this 25-year loss of life? And these were the reasons these were the health issues that resulted in the death of these individuals who were counted in this study. And if you look at the top 4 causes, those are heart disease, cancer, cerebrovascular, that's things like stroke, and chronic respiratory. And so if you take a look at those top 4 reasons, many of them are attributed to smoking. And so we always think it's really important to remember that and to continue the work. And so after that statistic came out, a whole lot of money from the federal government went into funding programs to address these health concerns among individuals with serious mental illness, to try to make a dent in that number because it's outrageously high. Slide 12. Next slide, sorry. So that was an overview of the total impact of tobacco with a more narrow focus on mental health. And now we're going to introduce the Choices program, which is a program that's run out of Rutgers in New Jersey. And so the next slide. So in 2005, there was much resistance to addressing tobacco in mental health systems. We heard things from mental health providers, including counselors and doctors and nurses, really things like, just let them smoke. Smoking is the least of the problems. And at the time, our medical director, Dr. Jill Williams, had already been devoting her career to the topic of smoking among the clients that she was working with for several years. And so she had been doing things like clinical trials, trying different medications. She also did things that were observational studies, kind of observing the patterns of smoking among people with mental health diagnoses. She also was involved with counseling studies. And so all of this work that she was doing was, with sort of moderate success. And so at this time, the peer movement was really starting to take hold and gain momentum in our state. And so she thought it would be a really innovative idea to, instead of having herself, the doctor or the counselor or the nurse go in to address tobacco, let's have the peers get involved. Let's have peers get involved because there's so many benefits to that approach. So much value to that approach. And so she then got together with the Mental Health Association in New Jersey, and I'm going to talk a little bit more about that. But before she could get this program started, let's switch just to the next slide. Before she could get the program started, she thought it would be important and helpful to get input from clients who were being served in the mental health system. So rather than, listening to the health professionals, she wanted to get input directly from the individuals who were most impacted. And those were people who were receiving services in mental health agencies in the state of New Jersey. And so because this was a way of really getting a better understanding directly from the horse's mouth as to what were the opinions and concerns and barriers for folks who were struggling with tobacco. And, this was really, really helpful in getting support from outside agents. And so there, if we go to the next slide. So we distributed 254 surveys throughout the state. These were at routine encounters at mental health agencies with mental health clients who were being served there. We had a breakdown, 45% female, 55% male, with an average age of 45. 69% were current smokers. So remember what we talked about earlier, what the national average of smoking is around 16%. Well, geez, what's happening? 69% within the mental health community were still smokers, and their average was around 18 cigarettes per day at that time. So next slide. So when we really got input, we asked some really basic questions, and we just wanted to ask, is smoking a problem for you? Well, look at this. Almost 70% said, yes, smoking is a problem for me. And not only is it a problem for me, but only almost over 70% of people said that they had tried multiple times to quit. So in other words, if we go back to what the health professionals were telling us was that it was not an issue, not a problem. Well, this gave us evidence that that was absolutely false, that this was a problem and that folks had tried numbers of times to quit. And so if we look at the next slide, we looked a little bit more deeply as to what may be some of the barriers to why they weren't having success with quitting. And so when we asked the question about confidence, so how confident are you that you could quit smoking? What we saw was that more than half of the sample said they were either not at all or only somewhat confident. It seemed like, this was a big barrier. Confidence is something that can be so crucial in making any kind of behavior change, but yet, we also know when you've tried to do something over and over and over and over, what happens to that confidence? What happens to that motivation? What happens to that drive? But really kind of reduces. You really kind of get beaten down with this. And so we noticed that that was one of the big barriers for folks. Okay, the next slide. So then we asked, if we had some services available, if there were some treatments available, would you be interested? So on this slide, the first set of bars, you see the navy blue and then the lighter blue and then the, I don't know what color, periwinkle. We asked if in that first set of bars, if people would have an interest in nicotine replacement therapy. Those are the patch, the gum, the lozenge, the inhaler, and the nasal spray. And take a look, lo and behold, about 45% of people said, yes, I would be interested in trying something like that. Then we asked them if they would be interested in Zyban, that's Wellbutrin or bupropion, and about 30% said, sure, I'd be interested in that. Then we asked if there was a group at your mental health agency to address tobacco, would you be interested in attending? And almost 40% said yes. We asked about individual counseling. That was a little bit lower in the 30%, 35% range. And then we asked if there was an interest in telephone counseling for quitting. And that, again, was a little bit lower, around 20%. But heck, there certainly was some interest in treatment. And we were identifying what the barriers, one of the barriers were, which was the confidence. And so if we look at the next slide, we asked the question, do you think that your mental health provider should be giving you treatment to quit smoking? And so over half believe that their mental health provider should be doing this. Oftentimes clients are spending many hours in these programs, and their providers are often trained in addictions and behavior change. And so, sure, why not give me some treatment, give me some kind of program to deal with tobacco while I'm here. And so this was a really, I think, a wake-up call for providers, and also a great, support of the idea of choices, which was to bring the tobacco message into these mental health programs by a peer delivered approach. So take a look at the next slide. This was some of the comments that we heard, and this was also really sort of inspiring us to get this work going, and so what we heard from the respondents were, with the mental health system, smoking was always condoned. Everyone simply smoked. Smoking was a way to pacify me. My family would bring cigarettes. I smoke because I'm bored and nobody cares. We also heard things like, I increased my smoking due to lack of activities in the first psychiatric admission. We've heard this time and time again, people saying that their smoking got worse in the mental health hospital, in the psychiatric hospital. And that's really outrageous when you think that this is supposed to be a healthcare facility, but yet people are experiencing worsening addiction to tobacco while they're inside hospitals. Sometimes they're even smoking more. And again, so this is back in 2005. There's been a lot of change since then, not complete change, but there has been some change within psychiatric hospitals where it's not as prevalent as it was. We've even had people tell us they started smoking when they went into the hospital. So if we take a look at the next slide. So our conclusions were, listen, consumers have an interest in quitting smoking. Over half believe that their mental health providers should offer treatment, and most indicated lack of confidence was the barrier. And so Choices was born. So we look at the next slide. In 2005, we received a startup grant through the American Legacy Foundation, which is now that Truth campaign that I mentioned earlier. And that was a very small bit of funding to get this program started. And so this was done through Dr. Jill Williams, who's there in the photo on the left. She's still our medical director. And on the right side, you have Marie Verna, who at the time was the director of advocacy at the Mental Health Association in New Jersey. And so the official kickoff was on June 15th in 2005 down in our state capitol in Trenton. And so, once we collected these surveys, we, along with the MHA&J, were able to bring the issue to the attention of administrators and policymakers in the state. And so this model is really conceived as an innovative peer-to-peer approach where our Choices peers would go directly into mental health programs to deliver the message about tobacco. And so now I'm going to introduce, for the next slide, I'm going to introduce Deirdre, and she is going to describe a little bit about the role of peers in our program, what they do, and a little bit about the training that they've received. And Deirdre has been with our programs since very early years, around 2008, and has been, a key member of the program's success over the years. So I'm going to turn it over to Deirdre now. Thank you.
Hi, everybody. It's really good to be here. I'm a consumer tobacco advocate. My name's Deirdre, and I'm a mental health consumer, and I also quit smoking with the help of a New Jersey Quit Center in New Brunswick. So what is a consumer tobacco advocate? It sounds like I work for Big Tobacco trying to get people to smoke more, doesn't it? We all have been trained on tobacco, and we travel all over New Jersey to deliver the message. In our role as advocates, we are peer counselors, peer motivators, and peer educators. We spread hope that if we can quit, anybody can. So when we get trained, like when I first started, those early hours, I was learning a lot about, tobacco education, and I got trained on motivational interviewing with Dr. Mark Steinberg. I learned how to work with smokers. I learned about advocacy for people with mental illness, organizing events with agencies and how to keep a calendar, how to write an event report, and ongoing supervision. There was a director of choices back then, and we would all report to her, and she was working with us in the office for hours and hours and hours, and we did put a lot of hours in. So the next slide. Okay, so advantages of peer counselors. First of all, we know what it is like to have a mental illness and the challenges that go with it. We have found that the consumers are now more comfortable with us and trust us more because we've been there. We know what it's like. And then when I tell my story, I outline why it is a good idea to stop smoking, and people start to question their smoking. They want to quit after hearing our stories. We tell our stories. Next slide. Okay, so here's a picture of us at the 10th anniversary of Choices beginning. There's Wayne Holland. He was a consumer tobacco advocate with us at that time. There's Dr. Jill Williams. She's a co-founder of Choices. There's me in the middle, and I'm a consumer tobacco advocate. There's Lisa Evans. She's a consumer tobacco advocate. There's Trish Dooley. She's the director of Choices. And there's Yasmin Halim. She was a consumer tobacco advocate. And then there's Marie Verna. And can I just take a break for a minute?
Sure, we can, I think, go to the next slide if we need to, Deirdre.
Okay, next slide.
Okay, I guess somebody's at the door.
Yeah.
All right, so that's the virtual world, isn't it? That is the virtual.
I'm working. Okay, I got him from the health department. Okay.
All right. For a second. There we go. All right, Deirdre, just unmute yourself if you would. Oh, you're on mute, Deirdre. Okay.
Okay, peer-to-peer support. Somebody was trying to relay information to me, no big deal. So we stress that we're not about making people quit, but letting them know that they have choices. They don't have to be imprisoned by smoking and a smoking addiction. And so we get consumers interested in quitting by telling our stories, that it is possible to quit. We can do it. Anybody can do it. If I can do it, because I was a 3-pack-a-day smoker, I really had to quit because I was starting to experience ill health. And so, it's just, my story, I'll tell you what my story is. My story is that I started at a pack a day when I was 14 years old. And over time, I used it to cope with literally everything under the sun, from school, work, meeting people. In high school, I got to meet cool guys. There was this gang called the Denims. I got to meet them. In college, I was considered cool because I smoked. And, so to make a long story short, I would smoke and drink coffee And, that was kind of like my coping mechanism for anything that came up. And I got to the point where I was a 3-pack-a-day smoker. I never even tried to quit, not even once. And finally, I had trouble breathing. I probably had COPD, but I went to a pulmonary doctor and he told me, I had quit for about a month using the New Jersey Quit Center in New Brunswick. And it was really a very shaky period in my story, but I knew that I had to quit or I was going to come down with a lung disease and die. And the pulmonary doctor told me that I quit in time. And I hung on to that. I never had to smoke again. So I kept track of how much I was saving financially. I saved, since I quit, $227,000. And I'm living a better life because of it. And, I'm bringing in as much money as I was when I was working in the computer industry in San Francisco. So I'm definitely bringing in a lot of good money, and I'm able to keep it and give myself a raise. So I think that's it for me.
That's great, Deirdre, and thank you so much for sharing. That's that number just keeps, Deirdre's been keeping track of that since you quit. What was your quit date?
9/12/2007.
Yeah, so between the money you've saved from quitting and the money you've made from choices, you're raking it in. Awesome. Okay, so then we're gonna have the next slide, we're gonna have Azim, I think. So Deirdre, if you wanna turn off your camera and your microphone, that would be good. Azim, you there?
Yeah, hi. My name is Azim. I'm also a consumer tobacco advocate, and I just want to give you a little information about, so obviously we've usually, pre-pandemic, we were doing all these presentations in person. We'd go to, out to groups and give our presentation. And so it was an educational presentation. We have a handout prepared, 6-page handout, and in it would detail several different things: what's in cigarette smoke, illnesses caused by smoking, what happens when you quit, why are cigarettes so addictive, healthy coping skills, medications. We covered some stuff about e-cigarettes. We're actually we're incorporating a part on cannabis now. And of course, we shared our story. So those were the things that were included in our presentation. And also at the end, we'd give what are called individual feedback sessions where we do carbon monoxide readings. And on the next page, if you go to the next page in the presentation, so this is the individual feedback session we do at the end. We do a carbon monoxide score and feedback. Then we calculate how much cigarettes cost each individual consumer for the year. And then we discuss different treatment resources like, nicotine replacement therapy, anything that could help them, maybe the quit line. And these would all be delivered we learned motivational interviewing when we first trained to become consumer tobacco advocates. All right, let's go to the next page. And of course, we also did health fairs. Obviously, we haven't done this in the last 2 years, or actually a year and a half because of COVID. But over there, we did quite a few health fairs. We do carbon monoxide readings, we distribute educational materials, and we do the same consultation regarding different treatments. And on the next page, so in the last year and a half, due to COVID, we basically transitioned completely to online presentations. Initially, it was a bit shaky. I mean, I'm not gonna lie, we didn't really know what we were doing. And I think that was true for everybody. But now we're really good at it. We do it all the time, at least like maybe between 10 to 12 presentations a month online. and it's going really well. Actually, we are transitioning back to in-person next month, so that's going to be a big thing for us, but we have been doing virtually for the last actually over a year and a half now, I think. All right, I'm going to hand it over to Lisa now, and she's going to go over the next part of our presentation.
Okay, thank you, Azim. Next slide, please. Hi, everyone. My name is Lisa. I'm also a consumer tobacco advocate with Choices. And what Azim was talking about was when COVID hit, like everyone else, we didn't know exactly what to do for the last, so the history of the program, we always went out to see our smokers directly. So what we decided was we wanted to add something more relevant to the presentation for a reason for people to, tune in and talk to us even while all this other craziness was going on. So we wanted to talk about what they believed about COVID, explain why we should talk to smokers with serious mental illness about COVID, and how does COVID affect smokers and what you can do about it. So before I actually talk about our presentation, I want to tell you, as you keep hearing, we talk about telling our story as Deidre did. That's just how we look at it. And so before every presentation, I try to tell my story, and I always introduce us as who we are as Choices, consumers helping others improve their condition by ending smoking. And I also let the audience know that we are all mental health consumers and we're former smokers. So I always considered myself to be an unapologetic smoker. When people talk to me about quitting smoking, especially about the cost of smoking, I would absolutely laugh. I would push back. I could smoke if I wanted to, I could afford to. What did it matter? Sort of, response that I got. And all along, honestly, I was concerned about my health, but I was afraid to admit that I had an addiction that was I couldn't handle, and I couldn't stop smoking. So I've been battling depression for many years. And one day, as it happens, I lost my job. And it was in the year 2009 when a lot of people lost their jobs. I was in shock. And it was worse because my son had lost his job the year before. And now there were two of us who had no money. The bill collectors were stressing me out. The phone just absolutely wouldn't stop ringing. They were saying mean things to me and I was hounded. And it's not good for a person that deals with self-esteem and depression. So neither my son or I could find jobs. I mean, we had no cable television. I had to let the cell phone go and use the landline to look for a job. And my landlord took me to court. That was the biggest thing of all, and tried 6 times to evict me. Now, I don't deal with the law at all. So it was very, very scary to sit in a court of law and know that by the time you left that court, you could be homeless, as I saw happening to some people. I was absolutely stressed. One time they came and repossessed his car. And honestly, I didn't know what they now call food insecurities, but although I wasn't starving, our situation was, we'd have tuna and no bread, or there was bread and mayo and no tuna. So I didn't have enough money to buy groceries consistently, but I have to say I consistently bought cigarettes. So my son and I both smoked. And it happened that he was Newports and I was Newport Lights. So God forbid we'd share cigarettes unless we absolutely had to. At that time, cigarettes were $7 a pack. And I know you're in New York where you pay much, much more for cigarettes. We spent $14 a day, $98 a week. And that came out to $396 a month. So we're talking 11 years ago that we smoked. And $396 a month 11 years ago was a lot of money, because it's still a lot of money today. So we couldn't afford to pay our bills, buy food regularly, and there just wasn't enough money coming into our home, but we could smoke. And so the first thing we did when we got an unemployment check was pay off the local bodega, stock up on our cigarettes. And if we didn't have money here in New Jersey, we can buy loosies. I don't know what you do in New York, but if you got 50 cents, someone will sell you a cigarette. So finally, my son said, we just couldn't afford to smoke. And for the first time in my life, I openly admitted that I couldn't. I didn't think that day would ever happen, but I went to a smoking cessation program at Robert Wood Johnson Hospital, and I met with the counselor weekly. She gave me the patch, Wellbutrin, and inhaler, and we're going to talk about those NRT today. I almost quit, but in that year, the government continually threatened to end unemployment, and I was so scared I was going to be homeless that I just went back to the comfort of smoking to help me get through. And then 7 months later, my counselor started Stop Smoking group in the evening, and I went back on medication, and I was finally able to quit. So for another 2 years, those bill collectors hounded me. My landlord took me to court, and we were hiding our cars and all the bad things that went along with going through unemployment. But in spite of that stress and pressure, I managed to not smoke, and I am so much happier, healthier, and I have more money because of it. And that was 9 years ago. Everyone's journey to ending smoking will be different, but the end result will always be a healthier and financially richer you. I just hope you don't wait like I did for 41 years to try to quit. So next slide, please. Okay, so we talk about COVID beliefs, and there's a lot of confusion surrounding COVID, and I think that's why I went to the word belief. I think I'm honoring everyone who's in the room, who's listening to me, because there's a lot of things that people believe. There's something called facts, but for our purposes, I just want to make sure that those that don't believe the virus is real is understood. There are people that think only elderly people die, children cannot get COVID-19, and smokers don't get the virus. There was some belief out there and a study out of Europe that some people could point to. Also that young people don't die from the virus. Next slide, please. So here's some data. I took this Tuesday, October 12th, when I sent the slides in. And at that time on the CDC website, this is some information that shows you about facts versus our beliefs. Regardless of where you get your beliefs from, the facts in this country actually come from the CDC and are usually, I would say, our state websites. So, when they say that children don't get the virus, well, they do. That may not appear to be a lot, but that amount is growing in the year and a half that I've been looking at these numbers. The group that mostly has COVID would be the group between the ages of 18 and 29. And more importantly, if you look at people age 65 and older, they make up less than 15% of the people that get COVID. But if you go to the right side of the screen, you see that people over the age of 65 make up only 75% of the deaths. And it's very nominal in the age group of 18 to 19, but it is slightly increasing in the number of deaths that are now happening to young people. So this is a little bit different than what people believe. These are the actual facts, and we always encourage people to go to the CDC website or talk to their medical professional in their lives that they trust when it comes to discussions about COVID. Next slide, please. So here's 4 of the slides that are part of the presentation. There's quite a few more, but we go over the risks for serious illness and, heart disease, COPD, of course, are related to smoking. A person might be at increased risk if they have asthma, high blood pressure, and again, smoking. So, the tie is to information about smoking. And in the state of New Jersey, when we were first able to get the vaccine, people who smoked ranked up there with people over the age of 65. A lot of people were upset about, but public health officials in New Jersey felt that people who smoked were at high risk for getting some sort of severe illness from COVID and could potentially die. So we were able to get, smokers were able to get that vaccine before others. So some of the concerns for smokers is COVID attacks the lungs. Smokers are at greater risk for having serious respiratory infections just in general. Smokers tend to have those conditions that increase risk for serious complications like heart disease and high blood pressure. What you can do, we always talk about, washing your hands. This goes the same for smokers as well as non-smokers. Use hand sanitizer. Wear a face covering or mask where you feel uncomfortable in large crowds, and, social distance, or at least apply to regulations in your state. So if you smoke, you should consider quitting or reducing the number of cigarettes that you smoke daily. We generally just say you should consider your cigarette smoking. We try to emphasize not sharing cigarettes because you can get COVID from germs. So, protect others and smoke outdoors or vape to limit secondhand smoke. Next slide, please. And so Trish already went over this, but I too asked the question when I'm in person, how many people do you, what percentage of the population do you think smoke? One thing to note is that the behavioral health community, which is mental health illness and or substance abuse disorder, makes up 25% of our population, but actually we consume 40% of all cigarettes sold. That's one of the reasons why we have added COVID to our normal presentation of information about smoking. Also, people with 3 to 4 times with schizophrenia are 3 to 4 times as likely to smoke as a general population. Going back to the information that I got on October 12th, this slide shows what has happened in the last 7 preceding days to the date of October 12th. There were 596,385 cases, new cases of COVID. That's just new cases. And there were 9,051 cases of deaths in that preceding 7 days. So COVID is going down in terms of percentages, but there still are parts of the country where these numbers are increasing. So to date, since the data started January 21st of 2020, there have been 714,243 deaths. So I will have Azim now talk to you about how he actually quit smoking.
Okay, thank you, Lisa. So I'm just going to quickly share my story like Deirdre and Lisa did. So the addiction to smoking began for me about 30 years ago when I was in high school. And I started like most people do because I want to fit in, I want to look cool. But that quickly developed into an unwanted addiction that I desperately wanted to end. My parents also got divorced during that time I started, and I had a lot of pressure to do well in school. Like I said, I want to fit in, I want to look cool. This combination of stressors got me hooked, and there began a lifelong struggle with the addiction to smoking. In college, I would swear to myself at night right before I slept that I would never smoke again. But then I would wake up in the morning only to have the very first thing I do is reach for my pack of cigarettes. I was also very depressed and anxious during my college years, and I had the mistaken belief that my smoking actually helped with my depression and anxiety. During my early 20s, I developed what's called bipolar schizoaffective disorder. And even more so, I believed that I needed cigarettes to cope. So I smoked and tried to quit over and over again for what seemed like an endless amount of times. Sometimes I felt that smoking was all I had in life, so why give it up? Then when I was around 35, I got the diagnosis of being pre-diabetic. I just recently had a major, nearly 2-month-long manic episode, but then I got severely depressed and I had been smoking like a chimney. In addition, I gained a lot of weight due to the medications I went on. So I felt horrible and I knew that I was slowly killing myself. That was when I learned about a quit smoking study going on at the Robert Wood Johnson Hospital in New Brunswick, New Jersey, with bipolar schizoaffective patients. So I went and talked with the researchers and I started on the nicotine patch. I did stop smoking for a while on the patch, but one day I caved in, I ripped the patch off, and I started smoking again. At that point, my hope was dwindling that I would ever quit. I then switched to the nicotine lozenge and I attempted to quit once more. So the lozenges also help, but one evening of a really stressful day, I was ready to cave in yet again. My cravings were probably the most intense they had ever been. So I was driving towards a Wawa convenience store, about to stop for cigarettes, when I kind of had this flash of insight that if I didn't give in right at this moment, when my cravings were at their absolute worst, maybe I could come out victorious over the lesser cravings in the future and quit for good. So this moment at Wawa was a huge turning point for me. I actually drove past the convenience store, almost in disbelief that I was doing so, and I never looked back. That was nearly 10 years ago, and I never smoked again. I learned at that moment that when you feel the greatest weakness and craving, if you don't give in right at that point, you're probably going to win the war on your addiction. And I was able to, and it changed my life forever. Over the years, my health has improved dramatically. I can climb the stairs, I can breathe fully without coughing, I can work out, I can enjoy situations where before I was always anticipating having my next cigarette. My anxiety and depression have gone down. I reversed my prediabetes, and as you can imagine, I saved a lot of money. So quitting smoking is, I believe, one of the single greatest gifts I've ever given to myself. It's made my life that much better. And remember that when you think you're at your lowest point, about to give in, when the darkness has descended almost fully, try not to give in. Maybe you too will have what I like to call my Wawa moment and never look back. You too can conquer this addiction, and I wish you the best of luck. So that's my story. And, we share it every time we go out there. We all share our stories, and it's very helpful. People can relate to it. So I just want to know, how much time do we have left? We have a bunch of other slides, and I just want to make sure that we maybe have, or maybe I can go over some of them a little quicker.
We have about 10 minutes, Azim, so
10 minutes? Okay, so Deirdre has to go too. So I'll just quickly, so this is kind of an abridged version of our presentation, but we go over what's in cigarette smoke. I tell them that there's 7,000.
I already went part of it, but I'll finish up if you just go and hand it over to me then.
Yeah, well, I'll just go over the next few slides really briefly, and then I'll hand it over to Deirdre. So what's in cigarette smoke? Then we go over some of the toxic chemicals in cigarette smoke. I kind of briefly go over that nicotine isn't really the substance in cigarettes that's killing you, and that's why nicotine replacement therapy can actually help you quit smoking, because you're getting what you're addicted to with nicotine replacement therapy, but you're not getting the actual chemicals that kill you. And then I go over the risks from smoking, all the diseases you can get, how the tar circulates around all your cells of your body. So a lot of different cancers, a lot of different diseases. And then I'm going to hand it over to Deirdre to go over the next slide there, the healing timeline. Deirdre, you there? Oh, I think Deirdre has stepped out. There she is. Okay. You're muted right now. So yeah.
Okay, everybody. What we're going to go through is the healing timeline. Basically, after only 8 hours after quitting, the amount of carbon monoxide in your blood drops back to normal while oxygen increases to normal. 1 to 9 months after quitting, coughing, sinus congestion, fatigue, and shortness of breath decrease. If you're a heavy smoker, it can take some time, but it does come back. And then it keeps healing until you have 15 years off of smoking. Your risk of heart disease and smoking-related death is now similar to that of someone who never smoked. Next slide. Okay, so here we have pictures of nicotine replacement therapy, and that the nicotine replacement therapy helps reduce nicotine withdrawal and craving side effects by supplying your body with nicotine. It it contains about 1/3 to 1/2 of the amount of nicotine in most cigarettes. When people quit smoking, the levels of those chemicals drop. Their bodies react by having nicotine withdrawal symptoms such as anxiety, irritability, restlessness, decreased concentration, increased appetite, and depression. Nicotine replacement therapy is safe when used properly. Tars, carbon monoxide, and other toxic chemicals in tobacco cause harmful side effects, not the nicotine. When you inhale tobacco smoke, the nicotine in the smoke moves quickly from your lungs into your bloodstream, providing instant gratification. The nicotine in replacement products takes longer to get into your system, helping the smoker decrease their dependence on nicotine over time. And one of the things they told me at the New Jersey Quit Center was that you want to make sure you're getting enough nicotine in these products. So you may have to use them in combination with one another. Like in the beginning, I was using the patch nasal spray, and the inhaler. I had plenty of nicotine, and I wanted to make sure I got enough product in me to help with the cravings. So what are e-cigarettes? You may have heard of vape sticks, vape pens, or e-hook, and you may say that you vape, not smoke. These are common terms used for the electronic nicotine delivery system, or e-cigarettes. E-cigarettes are a simple device that uses battery power to heat liquid nicotine, flavors, and other chemicals into an aerosol. Many people believe that using e-cigarettes is safer than smoking cigarettes, and that a smoker can quit cigarettes using e-cigarettes. Obviously, saying that a product is safer than cigarettes does not mean that the product is safe. Obviously, it does. And the main ingredients used in these cigarettes are nicotine, propylene glycol, vegetable glycerin, and flavorings. That said, there's researching suggested that e-cigarettes might assist tobacco smokers in quitting smoking. Most e-cigs deliver significantly lower levels of exposure to potent lung carcinogens and cardiovascular toxicants. They do contain some toxicants, but considerably less than traditional cigarettes. These findings are significant, but more research needs to be done. At this point, we can only advocate the use of FDA-approved methods of quitting smoking. And those are all the ones in the pictures here. You can use nicotine, set a quit date. And once you set the quit date, you can use nicotine gum, nicotine lozenge, nicotine patch. You can get those over the counter. You can use nicotine nasal spray or nicotine inhaler. Those you can get with a prescription from a doctor at your pharmacy. Then you have 2 pills, Chantix, which has got a high success rate, and Wellbutrin, it depends on the person. Sometimes it works, for some people it doesn't. With me, it didn't, but you can use the Wellbutrin in combination with any of the products, nicotine replacement therapies. So that really helps. I think it's Lisa's turn at this point.
Thanks, Deirdre. Yeah. Lisa, you ready?
Yes, I am. I apologize. Next slide, please. Okay, so this is very important at the end of it, and I know we're running out of time, but This slide indicates where we tell people to go get help getting smoking. What's universal is everyone can go to their primary care physician, they can go to the psychiatrist, they can go to their counselor. We encourage them to go to staff at their program. We've been doing this for so long. Many of the staff members do know how to contact us, even if they don't know themselves where to refer people. You can get the nicotine patch, the gum, and the lozenges at your local pharmacy. Now, we have 2 internet locations and a toll-free hotline. Those are New Jersey help centers. You too can find what's available in New York for your consumers. And then we just go back over what we discussed when it came to COVID-19 pandemic to remind people. Next slide, please. And the last thing we do is we offer a free resource, which is our newsletter. And all of us at Choices, and our management as well, we write articles for the newsletter. These are all full free resources, and people can, consumers themselves can write an article. We do poetry. We've taken pictures of paintings. We do lots of stuff, and we put it into our newsletter, and that's twice a year. Our website is njchoices.org. I welcome you to look at it. We hand out brochures and handouts, whether in person or at health fairs. And we have a tobacco treatment resource directory. Trish?
Thanks, Lisa. And Lisa's modest. Lisa is actually our newsletter editor and creates these beautiful publications twice a year. And you can, and she's also, she built our website, which is njchoices.org. So I heartily encourage you to check these out. There's lots of great information on there. You can reach out to us. We're also always accepting, I see in the chat boxes, there's lots of people's stories. We love for people to send us their stories so we can include them in our newsletter, because you never know who you might inspire on any given day. And if you do contribute to our newsletter, we will send you a t-shirt. So anyone who's interested in that, you can go on to our website. You'll find my contact information there, and we can go from there. So I recognize that we're pretty much out of time because there's supposed to be a Q&A. If we could just go through really quickly, I'm not going to cover the research study, but basically what the research study that we did in 2009 and 10 said was, if you go to the next slide and the one after that, is that individuals who were receiving the Choices intervention had a much better experience talking with their peers about tobacco than talking about their smoking with their psychiatrist or mental health professional. And they also had, people who had come to the Choices presentation also had more quit attempts and more trying nicotine replacement therapy and had better overall outcomes. And let's just pop over to this next slide. Since its beginning, these numbers, and I think they'll read, if you push the button, all the numbers will come in, but this is just sort of, if you push, let's see, does it I think it's like an animated type of thing. And if you keep pushing, these are the places we go. And since 2005, the team has done over 1,600 site visits, met with over 50,000 consumers. We are completely free service, and we're really desirable because we come to the program. The next slides just talk about some of the awards and recognition that's been wonderful. All of this is also on our website. Go to the next slide. Some of the awards we've gotten through SAMHSA, Mental Health America, the American Psychiatric Association, and we've been involved and consulted with the American Lung Association on various efforts. If you look at the next slide, you'll see Deirdre there with Dr. Jill Williams and the Surgeon General at the time. And that was during a presentation we did in Washington, D.C., where the Surgeon General actually tweeted out a picture and a quote from Deirdre. So that was really exciting. for us, for the team. But just to back up for a second to the next slide and just kind of reflect and you know, we've given a lot of information in a very short amount of time. But the bottom line is that we want, you know, people who are struggling with their smoking to know that they have choices, you know, and that there are resources out there and you are entitled to accessing them. And so the next slide is just my contact information. And I recognize we're bumping right up into our time to end. So thank you all so much for being here. And if we, you know, I don't know if the moderators want to do questions, we're here. If there are live questions, or if we want to do it on the chat or whatever works.
Thank you, everyone. That was a wonderful, wonderful presentation. I think we've got about 5 minutes if there are any questions in the chat that could be answered. Susan, did you see anything that we might ask live?
We have a question right now. Does New Jersey, does Choices take remote volunteers?
That's a really interesting question, you know, given the environment that we're in right now. You know, we love volunteers. You know, we've over the years, we've had a number, we currently have another volunteer. There's two other members of our team, Cleo, who's in listening with us, and Terrence, who's a volunteer. But, you know, I would welcome you to send me an email and we could talk more about that and see what that would look like. Because, you know, I think it was, I'm not sure, it may have been Amanda who said it first, you know, we are always looking for tobacco champions. And I heard Amanda's word influencers. You know, I know that's the big word these days. I have a 19-year-old, so I know about influencers. And if we can get as many influencers as we can, we're happy to have that to spread the message, you know, to your peers.
Yes, and I think that OMH is very interested in hearing from tobacco influencers who would like to, you know, bring these messages out to programs in New York State. So absolutely, we're looking for people who are interested, and you can reach out to Trish, and we hope you'll also reach out to Amanda. I'll put her email again in the chat for everyone.
Thank you. And the one thing I was thinking, this is Rita again, is it would be wonderful if your advocates might consider holding a workshop on how to write your story and deliver your story in a way that's really compelling, because they did a wonderful job today. I thought their stories were fantastic, and there's so many stories that can be told, but to refine it and tell it in a way that really reaches people, that takes a little bit of work, and they have some practice with that. So I think that would be wonderful if they thought about doing a workshop like that.
I'm sure that they're always willing to share their experience, you know, and very graciously. So so please don't hesitate. If you know, we could have that conversation for sure.
That would be wonderful. Are there other folks who have questions for our presenters? We're getting a lot of positive comments and feedback, as I knew we would, because you guys do a great job.
I did see, Susan, you were handling a lot of the questions as we went through, so thanks for that.
Yes, I was trying to put in information about NRT, and you know, I always find that people may not be getting enough NRT, and then they feel it may not be as helpful as they had hoped. So we're always encouraging people to use, as you did as well, the patch plus one of the other fast acting. And
yeah,
you know, people may need to use more NRT and longer, and that's okay.
Yep. And we address that during our presentations as well. I think Deirdre mentioned that. But, you know, and that's the thing that we miss about going back and being in person. We like to when we're able to do those individual feedback sessions with the carbon monoxide, that's when we can really kind of talk one-on-one, not pretending that we're medical professionals, but that we're telling them, you know, what the data is and the safety studies. And so it's always great because, again, like you said, you know, people have tried different things, but if they didn't use enough or they didn't use it for long enough, they again perceive that as failure when it's really just, you know, needing to tweak the medication a little bit.
Yes, definitely.
Well, thank you all. I'm going to go ahead and move on to the last portion here for our wrap up. So I wanted to mention for those of you who are on the call, the next in our series is on Thursday, December 9th from 2:30 to 4. And that's going to be more about sharing strategies and treatments. We have a team that has, you know, taken various strategies and woven it into their stories, and we'll be talking more about that. So that'll be with Amanda Sake and Susan Friedlander and Tony Trahan and Gita Enders and Regina Schoen and Oscar Jimenez Solomon. I think that's our team for that next session. Again, here's Tricia's email address, and we will be sending out a handout with these slides. So we'll be sending out the slides. The recording should be available within about a week, and then that recording will be converted into a continuing education course. You'll be able to get continuing education credit once the course is posted on the APS site. So that'll be about a month from now is my best estimate. Once you go there, you won't have to watch the recording over again, but just take the test and complete the course evaluation. And I will be sending out a quick evaluation just for the presenters today. Just how did this go? That'll be just a quick evaluation for you to let us know how we did, and you'll get the handout. You'll get a resource file with the references for this and the slides for this program when you complete that quick evaluation. So again, the references will be in that handout. And I just want to say on behalf of the Academy of Peer Services and our virtual learning community, thank you to New Jersey Choices. You did a wonderful presentation today, very impactful, and I'm sure that you've really given a lot of great thought for people to take away with how they can be champions of talking about tobacco. For any questions related to today's topic or ideas, you can reach out to us at the academy.virtual.community@gmail.com without a T. There's no T on the end of that, sorry. And I also want to thank my colleague and friend, Mariam Hassamuddin, for doing tech support today. She's always a great help with all of that, and she just is, I'm very grateful to her for her help as well. So thank you, everyone, and have a great day.